Welcome to the Roetzel HealthLaw HotSpot. HealthLaw HotSpot is a podcast for physicians and health professionals that covers the legal issues and trends that affect the healthcare industry.
Hi, everyone. Welcome to the HealthLaw HotSpot. I'm Ericka Adler, a shareholder at Roetzel and Andrus and health leader of our health law practice group. I'm joined by my partner, David Hochman, who's also part of our health law group, and he's also partner in charge of our Chicago office. Our very special guest today is Dr. George Mayzell, and we're really excited to have him here with us. Today, he's going to be talking about physician burnout and whether that's the next pandemic. Dr. Mayzell is a physician executive who specializes in helping healthcare organizations transform their delivery of care through population health strategies, care management redesign, and physician leadership program. His extensive career spans more than 2 decades and includes working with healthcare hospitals, health plans, integrated delivery systems, as well as clinical practices. And we're really excited to have you with us today. So thanks for joining us. Um, we seem to have lost my partner there, but I'm sure he'll join us back in a moment. So why don't we start by you telling us a little bit about why organizations should focus on burnout? Why is it important?
Well, first, let me take one step back and talk about what it is, just briefly.
Sure.
And it's really, and burnout's a horrible term, but we're going to use it for the sake of clarity. It's really exhaustion, not just fatigue and tiredness, but an exhaustion that's day in and day out. You just a low motivation. It's depersonalization, where you feel like you're removed from the whole scene. And it's also feeling like you can't get anything done, like anything you're doing is not effective. And why you should care about it is because right now, well over 50% of healthcare providers are feeling at least part of that syndrome. And the effects of that really affect all of us. So it's about quality. It affects quality. It affects patient safety. It affects how we get healthcare. It affects how we can get the delivery of healthcare. So it has huge financial implications as well. They think it's about $1 million for replacing a physician. So if you think about burnout and the presenteeism and absenteeism and the staff turnover that comes from burnout of physicians, but we could be talking about nurses too. Millions and millions of dollars. I saw a figure of multiple billions of dollars in the healthcare industry due to what they think is really becoming the new pandemic. And again, we got a little reprieve with COVID, but we're going to see more and more burnout post-COVID.
Is there more burnout because of COVID, or was this kind of a trend that was occurring anyways?
Well, there was a lot of burnout before COVID, but I think COVID almost gave us a reprieve, but also an accelerant, because you think about it, the healthcare sort of geared up like for a big game and got in there and went in there and had to do what they had to do during the COVID crises. But as we're winding down, we're seeing more and more burnout post-COVID starting to affect things. And again, COVID was a huge impact on the delivery system of healthcare. We see the docs in the hospital with the mask and gowns and stress and all that. But the other piece we don't see or really don't typically see is those folks went home to their families and worried about giving their families COVID. And they had the same concerns that all of us have about the people around us. Additionally, the physicians during COVID kind of broke into 2 groups. There's a group in the hospital that were, the intensivists, the ER docs, they were working their tail off, 24/7. But we had a large group of docs whose practices fell off, particularly early in COVID. So these folks who were the ones that are out in practice saw their practices get quiet. Elective surgeries went away. Office visits went away. They adopted through telehealth to a degree, but many of them saw their incomes plummet dramatically. So for the first time, I think that I can remember, all of a sudden, there were financial concerns among many of my peers that they hadn't really expected. Because again, there's usually an unlimited demand for healthcare in our country. So there were that 2 groups, both sort of some overlap, but very different concerns.
Is this burnout a lot of, our knowledge of it coming more from self-reporting? So doctors saying they're tired, they feel burned out? Or is it physicians quitting practice? Is it suicide rates, which I've heard have really gone up tremendously during COVID for physicians? What are the signs of the burnout?
Yeah, I think it's all the above. Um, and a lot of it's sort of under the surface. You don't really see it. We're seeing early retirements. We're seeing staff turnover. We're seeing low productivity. We're seeing medical errors. We're seeing safety concerns in the hospital. We're seeing suicide rates that I think are 3 to 4 times where they were before the burnout. We're seeing all that, particularly in women physicians. We're seeing it in nurses too. So we are seeing it all over the place, and it's having a dramatic effect on healthcare and the industry. And frankly, those systems that address it and deal with it and measure it head on are the ones that are going to be successful. This is going to be a competitive advantage. We already talked about the turnover and the cost, but there's also all those other things with quality of care and safety, and making sure you have adequate medical staff. So this is something that everybody's going to be forced to pay attention to, and should.
George, what kind of programs are hospital systems putting in place to try and help their physicians?
Yeah, I think a lot of those are really at their infancy. Some are doing more than others. I mean, the first thing is just to acknowledge it's an issue, um, and to sort of start measuring it and trying to figure out. And you can measure burnout directly. There's some tools, but it's not quite the opposite, but it's an easier thing to measure, is physician engagement. If you have engaged physicians, you don't have burned out physicians, or at least to a degree. So getting more engagement of physicians is really, really important. And I would really like to see this even go a step further. Most of us went into medicine for reasons, some altruism and so on. And what we want to do is we want to bring that joy back to medicine. We want to bring it back why folks went into healthcare. But we've got a lot of things to do. And to answer your question a little more directly, when we look at burnout, we think, and nobody knows for sure, but about 20% is, the person themselves. How resilient are you? I mean, we're all resilient. You went through residency and medical school. You have some resiliency built in. Um, but there's also 80% of it is the system around healthcare, the hospital, the delivery system, how people are paid, how the work is doled out. Um, you know, and really it's about all of the work, all the things that are not patient care. It's not patient care that burns out physicians or nurses. It's all the stuff that they feel like is involved in healthcare that doesn't really lead to better patient care. That's the stuff that's making everybody crazy. Um, it's all the bureaucratic stuff. It's all the insurance forms. It's that really big 3-letter word, the EMR. Um, those are the things I cleaned it up for the sake of the podcast, but those are the things that are making docs and nurses and everybody crazy, because you find yourself staring at a screen and not looking at the patient. Or we had dinner with a friend of mine who's a practicing doc, and he said he had 4 or 5 hours of chart work to do that this weekend that he just didn't have time to get through during the week, and we call that pajama time. And now what's happening is all these docs are bringing the charting home at night because they just can't physically get to it during the day. And again, does that really contribute to patient care? Yes, we need some charting, but not our current system.
Right. I guess the concern I have is that I don't see any of those things changing very quickly or anytime soon. I mean, the EMR systems are fairly new and robust. We've got the open note requirements now, so doctors paying even more attention to their records to make them even more readily available. You've got the prior authorization process that make doctors crazy. You've got all the documentation, and I think, yeah, it is making doctors crazy. It's burning them out, but there are so many different moving pieces. That's really not something the hospital can solve, really, right? It's not something it's not something the government can solve. It's going to take lots of different parties kind of contributing to change the system in a way, right? So what can they do, really?
I think it has to be solved at 3 levels, and you kind of brought them up. One, there's some individual things you can do: work-life balance, targeting work that you really like to do with some protected time, doing things for yourself that can, whether it's exercise or whatever your stress reliever is.
Right.
There certainly are some individual things. That's not the biggest bullet out there. The second piece, I think, is at the institutional level. And they're really, no, the EMR is not going away, although I've heard a lot of prayers to that effect, but it's going to stay. But if people start looking at workflow and using it more efficiency and using non-physician work to do things that don't need physician work and so on, and working at the top of the license, that whole issue. I mean, there are a lot of things that an organization, again, and remember, these organizations are now employing physicians, so now they're part of the solution and part of the problem. So how they handle the compensation model to support limiting burnout,
Right.
all those kind of things. So there's a lot that actually can be done at the organizational level. Although, again, as you said, there's no one fix. And then, of course, there's the larger level, which is the national, social, whatever level, where that's where we have to deal with how we handle payers and the requirements and some of political and other things that really would contribute to making it, again, what we want to do is have better healthcare. We just want to strip away all the stuff that's not about the patient.
Right.
And while I'm at it, I want to mention one thing, because I mentioned this earlier. We're using the term burnout, which I hate. I don't know a better term. I've heard another term, moral injury. I've heard a lot of other terms which are better, but still not it. This is not a personal failing of the individual physicians or nurses or healthcare people, which burnout seems to signify. This is really an issue of how the system's been created, that doesn't let the physician, optimize their care of patients. So burnout is really not the right word. That suggests you just couldn't hack it, and that's really not what this is about.
Right. I think it can happen probably in any profession where the burdens are too high. But let me ask you this. I mean, I think that physicians, I review contracts, so does David, and I can tell you physicians are always fighting to get as much money as possible. And so it's hard if one of the things they had to give up would be some of that compensation to hire a scribe or to be able to have that staff available to take some of that burden off of them. It seems like, almost a tension there, because these hospitals, I mean, they are businesses, they're looking at their bottom line, and it could, it's not that they might make less money. It's not that they're going to lose money, right? But so how do we bring those two concepts together? Like, who can really make this happen?
Well, and that's a difficult issue. I think there are a number of things that let the tide rise all boats. I mean, if you have, and scribes, you brought that up, there's some studies out there that say the increasing volume you can see if you put them in the right workflow covers their salary. Maybe not totally, but in some cases. So there are a lot of things they can do out there that really don't necessarily totally impact their finances directly, while still providing better workflow. Some of it's just building how you do things. The EMR was really never designed as a clinical tool. I mean, it was initially a billing and financial tool. We've adopted it to be clinical, but it's still, there's a lot of opportunities in how you handle how things happen through the EMR in an office, which really can make things much more efficient without sacrificing either patient care or, in this case, what we're talking about is efficiency and economics. Even the comp models, again, that might be a sensitive subject for your audience, but again, how you manage that, and whether there's some evidence out there that purely incentive-based comp can actually incentivize burnout, whereas some mitigation of that with some quality and other metrics and other things built in, goes the other way. So I think there's, like most things in healthcare and almost everything else, it's all about balance. It's all about, measuring things, and it's all about understanding where you are and where you want to get to.
Yeah, it's interesting because you see quality metrics in contracts with hospital systems, but you don't see them very often or as often in groups, in private practice. They're more productivity driven.
No, and you're right. And that's sort of a concern. But I think what we are seeing, and I think you're probably seeing this too, is we see some of these ACO models and other delivery systems which are pushing some of the financial risks down to the organization or the physician group or whatever. Most of those have at least a number of quality metrics built in as a hurdle for payment. And again, the question, to your point, is sometimes the groups don't always translate that down to the individual payment. And to me, that's a mismatch where the incentives were designed thoughtfully at the higher level, but then they become, and I've seen a lot of good things happen and bad things there. I think there's a balance there because, you don't want docs competing with each other for patients inside the office setting or competing with nurse practitioners and other APPs in that office setting. So again, nobody said this stuff was easy because it's not.
Right. So, well, I was going to say, how, if you're a young doctor and you're looking at employment opportunities, then how can you, what should you be looking for if you're trying to choose a job where you're most likely going to avoid some of these issues? I mean, most contracts I look at, the nicer ones are 32 patient contact hours a week, maybe 34, leaving some time for admin time. But many of them are a minimum of 40 hours per week. And I think that's really what's creating a lot of that burnout. Should doctors just avoid jobs like that completely because they're already setting themselves up to be overwhelmed? Or what are the other cues that we can advise our clients on when we're looking at contracts?
Yeah, I think a lot of it is looking at one, you want to make sure the values of the practice or the system line up with that physician's values. And again, most cases it's about patient orientation and things. I think looking at the hours and at least understanding, I mean, none of us ever work 40 hours a week. I don't think that's in healthcare or law. I don't think that's probably practical, but understanding what hours you are going to be committing and understand that if you have certain number of patient contact hours, there's also a lot of hours that are going to be spent on phone calls, renewals, all the things that happen outside that are typically non-compensated in our current fee-for-service models. So I think it's really about being where the other thing that's been shown to be highly effective with burnout is allowing the physician to do what they really like to do. So let's say they have a passion for geriatrics or a passion for ADHD or whatever it is. Let them have some dedicated time in those areas and also some dedicated time that's not directly patient care. So understand that there's some administrative time that even the new doc is going to be having involved in. And I think the new doc, they probably have exited the residency with $1 zillion in loans, and they're ready to hit the road and work. But just making sure there's some balance, and that comes with that value match of making sure the practice values is the same as that physician's values, because if they don't match, at some point there's going to be conflict. And that match has to be, how they value and the family time and that sort of thing. And putting that all in perspective. Do they have some control over their schedule? Do they have the flexibility to take an afternoon off if they have a kid's soccer game? Those are the kind of things that aren't always directly in the contract, but really get to be very important as you move in your career.
You see a lot of conflict between older doctors and younger doctors in terms of lack of a better word, work ethic. I remember when I started practicing, the doctors who had been in practice said, well, these younger guys don't want to work very hard. So those younger guys now who have associates of their own, they're saying these younger guys don't work very hard. So it seems to be a generational thing.
Yeah, you're going to get me in trouble, aren't you? I think I do see a difference. I think, and there's some good and bad with it. I think I see a lot of the younger guys really are much more focused on work-life balance. A lot of them are coming out, don't want to be partners. They just want to be, employees. A lot of them take a very different look, or they want to even work part-time, or they want to work a couple of years and then cut back. So there's definitely a different type of, they're obviously much more electronic savvy, so they don't, the things that make us crazy that we have to go to our kids and ask them how to get it to work, they know how to do. So I think there's definitely a difference. There's definitely some generational things, and that could be tricky inside a large practice with varying age groups of physicians. There has to be some flexibility and accommodation to understand that sometimes there are generational values. Obviously, there's a lot of individual things that go on too, but yes, I have seen that and I have noticed it, and it's good, but it's not all good and it's not all bad. So there's pluses and minuses.
Right. I think it's really just hard to know what an institution's values are. Most doctors are talking with a recruiter. They may or may not know anybody there. If they did get to meet someone, it might have been, while being supervised by the medical director or CEO or whatever. So you don't get a really good chance to find out those things, unfortunately, until you're really there. And I think despite everybody's efforts to talk about culture and the truth is that I think rules are often very strictly enforced and there's very little flexibility despite the best intent to give doctors that chance to attend a family event or whatever. I think smaller practices are even stricter that way. You would think that maybe they'd be a little bit more flexible, but very often they're not. Institutions often have, they're large enough, they're covered by FMLA, or they have an HR person and they know what the rules are. But in the smaller practices, I've seen them be just, unfair and uncaring, I would say. I had a physician whose wife had a very difficult labor and recovery, and he needed some time off. And it was just a battle for them to even let him have time with his family. And, really, how can you really know that ahead of time? You really can't. But what I like to say to my docs, and David, I don't know if you do this as well, is when I'm looking at a contract, whether they're a new doctor or a more experienced doctor, I like to actually give them the questions that we've come up with and have them have that conversation with their contact, because I think that really gives a lot of insight into what that employer is going to be like, to work for. If they're like, everybody works this amount and so will you, or, that's the way we do it and we don't really care what your outside interests are. Like that kind of response, and I'm not even exaggerating when I kind of use that tone, but that kind of response is a little bit of a red flag. But if the money is so appealing to you and you got that response, you have to go into it knowing that you might be trading off something for another. So I think there's a lot of cues there. And, they're not going to come out and say, this is our philosophy. They often have a very nice philosophy in writing, right? But I think talking to them and asking those questions and listening to the responses is really the only way you can know if this is going to be a burnout situation or a very long, healthy relationship, right? It's hard to know.
No, I agree. You got to listen differently. You got to listen what they say, not what they do, not what they say. You got to ask for examples. You got to try to talk to some people around the hospital that may not be part of the group, but are either competitors and or referral sources or back, and try to get a flavor for what that group's really like, and then try to make. And it's hard because a lot of these guys are just getting out of residency and they're anxious and they're they're inexperienced, at least in the sense of those kind of relationships. But I've seen those relationships that you have. If you walk into those situations, and it's only about the money and the rest of it doesn't work, it usually doesn't last. Because again, life gets in the way, and and again, I think the younger generation is different. They value that family time and that work-life balance more in general. Again, generalizing, but yeah, to your point. And sometimes you can tell from the contract, because depending on how, the flexibility and some that are inside the contract, this better than I do, I'm sure, but you can get a sense for just how rigid they are as an organization. And again, that may fit some people's needs and be great, but it may not.
Right.
We have a lot of clients who, one of the major things or biggest concerns they have is the hours they have to work, scheduling, how much call. There are some specialties or some jobs where it seems like everybody has a special schedule, because some people want to work 3 12-hour days. Some people want to work 5 days a week. But their work life is important to them.
Yeah. And I feel sorry for those practices, because managing all those schedules is really tricky. But yeah, as we move down, being able to keep docs, keep them engaged, keep them happy with their job, limit turnover. I think that's going to be the value equation that gets organizations in a win column. The turnover, because as the turnover is, I already said, it's $1 million a doc up to. And that includes, again, don't forget, I'm sure this takes a while to get on health plans. I mean, it's not just about in and out, it's all the things that go with it. So the organizations that figure out how to minimize or eliminate burnout and bring back the joy in medicine, they're going to be the ones that are successful long term. Because again, the other thing I didn't mention about engagement and lack of burnout, when physicians are happier, patient experience is better, but not just experience is better, patient outcomes are better, and patients are more compliant. So it's not just about the physician and their satisfaction. It really trickles down into the patient and the delivery system. So the ramifications are huge.
Right. So it seems like going forward, groups and institutions really need to, if they're not already, take a close look at physician burnout and try and figure out how to do better. Because in the long run, the physicians are not going to do well in terms of their outcomes. They're going to lose employees, and it costs obviously money when you lose employees and can't recruit because of maybe your reputation in terms of physician burnout. So, I think a lot of these places think about things in terms of money, right, as opposed to quality of life. And so if that's the bottom line, then it's going to cost them in the long run if they don't put the money and resources and time into coming up with a program where everybody can win and be happy. Unfortunately, we already have a shortage of physicians in this country. This only contributes to it, not just physicians, but other healthcare providers, although I hear they hate the word providers. I don't know, be careful how I say it. But I think this is really helpful, and hopefully those listening understand why this is a problem and maybe have some ideas about what they can do in their own practices or in their own, employment situations to address it, and maybe some questions they need to ask if they're unhappy right now as well. Any final thoughts on this?
Yeah, no, I think you summed it up very nicely. It goes back to, if you don't acknowledge it and you don't start measuring it and you don't start talking about it, you'll never be in a position to fix it. And so understanding how important it is and starting to have those conversations and starting to measure engagement and burnout lets you address the problem, and then have conversations and see what things are easy to fix and what things are a little harder, but take a short, middle, and long range view to solutions.
Great. David, any last words?
No, I think that in addition to your and George's comments, I think that younger physicians, when they're looking for their first job or first jobs, need to investigate how these practices operate and make sure they have an understanding of what they're going to be undertaking. Not every job is for everybody.
Great.
Yes.
Absolutely.
Great point. A lot of stories out there on things that worked and things that didn't work.
Sometimes you have to learn through experience, but hopefully if people are listening to this, you get a couple of ideas of what to avoid, right? And just stay happy in their job. So well, thanks everybody for joining us. This has been the HealthLaw HotSpot, and we thank Dr. Mayzell for joining us today. Please join us next time, and feel free to check out some of our other podcasts. You can also find us at ralaw.com, and feel free to reach out if you have any questions or comments. Thanks so much for joining us.
All right. Thank you, everybody.
Advice. Use of the Roetzel HealthLaw HotSpot does not create an attorney-client relationship between you and the firm or any of its attorneys. The Roetzel HealthLaw HotSpot should not be used as a substitute for competent legal advice, and you should contact an attorney in your state about any legal needs or questions you may have.